So it's a 6-year-old kid, placed at 3, ADHD, anger outburst, defiant behavior, mood swings, clear functional impairment everywhere. This was his prenatal lineup: stress, nicotine, cannabis, alcohol, no FAS diagnosis. That sounds like every kid in your clinic. It's not unusual, folks. And he had neglect, domestic violence, and physical abuse. That was his complex trauma model. Good family. So when he came in the first time, he had a Vanderbilt that was compatible with ADHD, and that's supposed to be ODD screen. So he got the Antichrist to-do list. He had a mood screening. He was a worrier. He had panic that turned into anger. He was aggressive with his older biosib that was placed with him. Sleep was inconsistent. Often took 2 or 3 hours to fall asleep. Sleep quality kind of depended. It was kind of hard to tell. And they were losing it. And the school data also had a positive Vanderbilt. 92 verbal, 108 nonverbal, no evidence of learning disability. Some relational issues with peers. Adults love him when he's good. No ASD issues. Works better one-to-one. Fragile temperament some days. Some days he just walked in the door and he was really hard to be around. So he had excellent trauma-informed play therapy for a while when he first got placed. Somebody who I knew, and it was great. And now they're seeing a behavior specialist who really wasn't that interested in anything else. And say things like to him, that was a long time ago. Let's not use that as an excuse. Yeah, talk about triggering me. Okay, what's their number? Because basically she was telling the parents, God, if I had this kid, he would not act out. Awesome. He had OT for a bit when he was early on. Now what, doctor? Are there questions to ask? What's the profile? What's the plan? And when's the follow-up visit? Questions do you want to know after what I just said? 6. Hint, hint, it's about the anger. What do you want to know about that? How long? Yay! That's actually the key. Let's just go with how frequent, how intense. So all those things, yep. But how long was the key? Anxiety clarification, talk about that. I get more data on the sleep. And what about family history if they knew it? So, 2 to 5 T-storm anger, cool. Remorseful after each, and this is so common in foster kids. Can I still live here? Because what foster kids do is pack their suitcase after a meltdown because they're sure someone's going to call the number and get them to take them out. And they're going to maybe tell them they're going for ice cream. Surprise! And they're really taking them out. And it's a plastic bag, not a suitcase, unfortunately. It had a GAD feel, the anxiety. Didn't feel like it was part of the trauma because he'd already been treated for that. Sleep is clearly, in their mind, tied to the next day's behavior. That's one of the things you want to ask. What did that do? Sleep hygiene seems to be pretty good. Total sleep time is not enough. And that kind of fits. If he's taking 3 hours to fall asleep, that's 2.5 hours, not enough sleep. And the vague family history, maybe bipolar, I don't know, major trauma, definite drug abuse. Okay, that's about as good as you're going to get. That's more than you're going to get, mostly. So he was likable, nonstop moving around, no overt anxiety, no depression, a little tough to examine. Now the exam that we're going to be, somehow I'm going to get this, we're going to probably teach this when we start doing cases, but you can do a simple neuro screener and come up with all sorts of really nice evidence about kind of their Swiss cheese brain. It's really cool, easy to do. And we did do an FAS evaluation, and he had a 4 filter, which is one of the, it's significant. A 2-lip isn't. His eyes were small, so he was one of those kids who had 2 out of 3 features, but 1 was normal, so he doesn't have a diagnosis of FAS. It's got to be 2 C's and a B. That's the Washington system. And nice connection with mom. So here's his diagnosis profile. I'm stuck with ADHD for insurance, but I hate it. I usually wrote those things down: executive dysfunction and regulatory dysfunction. What the hell does that mean? Anxiety disorder unspecified, because we really don't know yet. History of complex trauma. Prenatal exposure. Sleep disturbance. Primary versus secondary. What about bipolar? What about bipolar? 2 to 5 minute episodes. No effing way. That's really, I think that's really kind of fun to go this, and you can quote me and the slides anytime you want to, because this is going to be part of the model. So you can put that in the record. My malpractice lawyer said it's okay. So what's the first step? Sleep. We're going to do that first. Fortify sleep hygiene, melatonin, clonidine, Reavel in 4 weeks. Clonidine was going to be a backup plan. We ended up doing both. And the sleep improved a lot. And big surprise, it didn't change much. I've had kids with those kids I mentioned on hour total sleep, and they have dramatic improvement on sleep and zero impact on the day. And you can't believe it's possible, but you watch it and you go, they really still are shot out of a cannon. But at least you know. That's why we do it first. Okay? But now, doctor, school's asking mom, has the doctor made his mind up about next steps? The school is dying. So, let's treat the ADHD first. That was kind of what the decision was. Do we use a stimulant? If so, what? Non-stimulant? What do you think? Based on, remember the anxiety. Yeah, in this one, it's not so awful that you wouldn't be faulted for doing a stimulant, as long as you said to them, we're going to abort this as soon as it looks like it's not working. And if you have parents that are willing, because some parents will go, oh, I don't want a stimulant, I really want that other one. If you get that reinforced, especially if they're meth users or their family history of cocaine, they will not want a stimulant. So that's nice. You can kind of decide, you can make the decision based on them. So, Strattera or Intuitive or Cat Bay, what are we going to do? Well, we talked about this already. The reason we wouldn't do stimulants. We can always do a stimulant trial later because it's fast. That's always what you can say to them. We can always come back with that, and it might work the first day. Because Intuitive is about a month. You kind of have to be patient with it. Now, some people still want to do this but it's just the risk and the benefit. I think it's just not worth using Strattera unless they've failed Intuitive. Now, I have some kids that have to have both because it's really the same model as Prozac and Boost Bar. You're getting the norepinephrine increase and you're getting the receptor agonist on top of it. Some kids need them both. So we did Intuitive. Again, I've had a lot of experience. We talked about this already. So here we gave them 1 milligram BID. We already talked about that. Improve regulation in all settings, decrease hyperactivity and impulsiveness, better compliance with behavior programs, no personality change, well tolerated. That sounds like a win to me. Talks more about his feelings. And that's a cool thing. In fact, that was a positive. They were like, that's so cool. He doesn't avoid it anymore. A little bit worse anxiety, but not yet OMG level. So let's hang. Are we done yet? Follow anxiety closely. If you need it, you can do either Lexapro or Boost Bar. And also monitor that intrinsic arousal, motivation, because this is a kid who might need a stimulant by the time he's 3rd grade. We'll track it. And if you're telling them all along, guess what? When you need it, they go, whoa, you called it. Helps your credibility. Great, cool. Or you can do an exercise program or some sort of OT thing at the school to get their arousal up when they first get there at school. Or the Activate program, if you have it. That's pie in the sky so far. How long to treat, how long to follow? Does he need more trauma therapy? What about FAS interventions? Yike. Well, there's some resources, but these are things that I think you do monthly visits for 3 months is what was my kind of typical, and then every 3, and then I had a handful of kids that I saw yearly because they were I hate charging them for every 6 months because I didn't do anything. I hadn't changed their doses for 2 years. So I just did their annual, and I tried to get them to go back to primary care, but they often didn't want to. Okay, here's another case. This is a 12-year-old, placed at 4, much more complicated. Similar things as the other kid had. Very similar, except this kid had opiate exposure. Similar complex trauma. A great family, but divorce rocks the family when the kid was 10. And all bets are off after that. At 7, when he first got seen, he had almost the same kind of stuff. And the school data was very similar. He had a little bit higher IQ. Math was a strength, some relational stuff. No, he really wasn't ADHD. So, clear academic underachievement. Originally responded very well to Adderall. Didn't have a lot of side effects. Hit the wall academically in 5th grade. Right when the parents were divorced, it turned out later that part of it was the FAS wall, because kids with FAS often have problems when you get to that level. Separation was a total bombshell to the kids, even though they were listening and heard him arguing. But boom, where's Dad? And the school performance went to hell. And the dad started using again. And it was a nightmare. And then abused the kid during the weekend that he had him. And he didn't tell anybody because he told him not to say anything because he blamed the kid. Of course he did. School behavior became untenable. He started throwing chairs. The room was clear. And mom was withdrawing, and that just confused the hell out of the kid. It was like, she hates me. And emotional withdrawal is really hard on kids. We see it in foster care all the time. It's usually one parent decides, I don't want to do this. You think the kid didn't notice? And outpatient therapy failed. Aggressive med treatment through CMH has minimal impact. And this, I hate even reading that. Residential care became the best option. What else are you going to do with him? They tried to send him to an aunt out of state, and that lasted like 3 days. Because again, what do you think? You don't want me. Nobody wants me. So here's what he was on when he got to residential. Gosh, I wish this was rare. 3 antipsychotics. Yep. 1 for sleep. And the rationale was, he was on Risperdal first, they put him on Abilify, they tried to wean the Risperdal, they got it down to 0.5, and then he fell apart, so they left it. Depakote, and he was still on Adderall, but any higher dose, he couldn't handle it. So, at residential, he was very reactive, very mad, worse in the afternoon and evening, lots of unpredictable behavior outbursts, Jekyll and Hyde feel. The staff really liked him, and then he'd turn on them, and they were betrayed, and he became a pariah inside the walls. This is very common. The direct care staff befriends the kid, and then it's like, he kicked me in the nuts. That kid is dead to me. Whoops. Think the kid doesn't notice? And then the kid said, these meds are killing me. That was the best comment made. It's like, I love him, because who does that? And he shuts down when he's frustrated, and then he blows up when they think it's safe. And again, the betrayal by the staff was really something. Okay. Bad executive dysfunction. Worse after school, because the Adderall was wearing off probably in 6 hours. And there was never a thought of another dose. Why would you do that? Lots of anxiety and panic. PTSD was overt now. All the scales showed it. We still weren't sure about FAS, and review of his record showed that both his parents had horrendous trauma as kids. So, after stabilizing, how can we link the findings of the assessment in congregate care, that's what CC stands for, congregate care, to med decision making? How do we do that? Should we wean anything? Which med should we wean first? Well, I'd say one of the antipsychotics, because he's in a place where we can watch him. So the rationale to the parents were, hey, he wasn't there before, so we'll be here. If he needs it, we'll know it. So we got rid of the Risperdal quickly. It was exciting. And the breaks treatment was, I was consulting at Eagle Village when this thing happened, and so I was sure, and sometimes the psychiatrist, I never get to talk to her, but she was doubting this. It's like, when have you seen Adderall XR last more than 6 hours? I haven't. It's almost always 6, maybe 7. A lot of times it's 5, and you got to realize Adderall XR, all the beaded release stimulants, pearl of the day. All of them are pH dependent. So if you don't have enough acid in your stomach, you don't get the second dose. Because the difference is half the beads have a thin coating, immediate release, half the beads have a polymer, and it is totally dependent on the stomach acid. So we used to have kids, then Dad would have breakfast on Sunday and they'd make a big carb pancake breakfast, the kids' meds didn't work at all. Diet Coke, weirdly, was what we would do in the morning with the kids because that's about as acid as you get. Or Diet Coke and orange juice. It was like whatever. And the Vyvanse scientists are the ones that told us this at a meeting. And they were kicked under the table because it was a big trade secret that Shire was throwing Adderall under the bus because Vyvanse was so different. And so the chemist told us this. And it's like every beaded release med, Vocalin XR, Ritalin LA, Metadate CD, interesting stuff, right? And we also had to think about, well, was the Adderall making his anxiety worse? We know it's the worst offender for that. So we decided next to wean the Adderall and watch the anxiety and also watch the fur fly. But again, he's in residential. So this is when you do it, right? So ADHD symptoms went up, anxiety was down, but we knew we had to do something else. So then we said, this is a Cat-V med. Because again, he's having tons of triggers. So this was prefrontal and the accelerator at the same time, and 24/7 executive function for the first time in his life. Guess what? It was a miracle drug for him. But motivation and arousal, not touched by clonidine and never will be, ever. You can push the dose to toxic levels and you're not going to have that happen because that's a dopamine issue. But can he handle Vyvanse to deal with that? So we wanted to see. He's still on Abilify, right? He's still on Depakote. Shitty anxiety treatment. So this was going to be the moment of truth, but we can do this in a hurry, find out. So we did it. The stimulants, either way, are quick. So 10 was really, really successful. Academics continue to be a problem because he couldn't concentrate. We went up eventually to 30. 30 was OMG anxiety. Whoops. Never mind. Back down to 10, regroup. So what we do next? Starts with an A. ANX. Treat the anxiety, right? Because he's not getting that treated. Because remember, we're going to get rid of those other meds because I'm convinced this kid does not have bipolar. It could, but it was so dramatic. We were thinking we didn't want to take the chance to take those away and then have the roof cave in. But it's a good point. In fact, I had to fight the psych for that. That's exactly what she said. So, because this is what she said. Well, you're just treating a side effect. It's like, yeah, but remember this is another pearl. Mood side effects are not normal stimulant side effects. They are not normal. If you have those to two different stimulants, that is a mood issue, mostly anxiety. That's something that Pine Rest told me in 1994. God, that was brilliant stuff. And I had so much relaxation in my mind when I knew that, because I would see that, yeah, Ritalin did this, Adderall did this, boom. This kid is anxious. We're giving him, and that back then you had to have a friggin' jury to tell you could do it. So, we talked about that already. So typically, we want to treat the anxiety by itself. So, what do you do with him? So we decided, because we didn't think he had bipolar, we decided to go with Lexapro. And very much improvement and no mania. And he told the therapist, maybe I've always been anxious. maybe I've always been anxious. Maybe this is it. It was an aha moment for this kid. And then we were able to creep up the Vyvanse dose to 40. Still halfway there. And so now he's on Cat Vape, 0.2 BID. He's on 10 Lexapro, and he's on 40 of Vyvanse. Guess what? Get rid of those other two. And we did. And we also got him off the Seroquel first, because what happened, once he was balanced, sleep kind of just vaporized and wasn't there anymore. That was fun. He ended up needing melatonin later, low dose. He had better therapy. Exercise was helping his overall function. And then we were trying to do a lot more mindfulness so he could handle it. And now he could do mindfulness without losing his mind, because all he thought about before was a divorce and how his parents didn't want him. So 2 or 3 months to get rid of all those meds. And the staff wanted to hurt me because they were sure this was all going to blow up. And we kept telling them, if it does, we'll know, right? Because you have to that he's so much better now, it's not even fair how much better he is than he was when he came in. And so, but I had to sell some ice cubes to Eskimos with that. I'm good at that. So, but yeah, again, he's impatient. This is when you do it. Not with a mom who's withdrawn and in the corner and is not available to him. You do it before he goes home. And this is what I say to them, why do we not do this in every residential admission? It's not a priority, but we're writing a grant where it's going to be the only priority. We're going to be working with the 5 worst residentials in the state based on the state's data. And I'm going to go into the lion's den and go, don't hurt me, but here's what we're going to do. We're going to keep track of the model and see what the hell happens. It's going to be exciting with federal dollars. And the direct care staff, wow, they did not want to believe it, but he was so much more lively when he was off those others. Again, the Depakote moment. His school got better because of that. And they could get the family involved, did a lot of Skypes. And Eagle Village has a little motel that families can come stay in. They use it for retreats, but it's very cool, and they can have visits in the motel, like a pseudo home visit as a starting point. So they were able to do all their stuff. Happy ending. So look at the difference. He came in on 3 antipsychotics, and I forgot the risk of the Depakote. Whoops. All those meds are accelerator except for the amphetamine, which was actually exacerbating his anxiety too. Other than that, it was a perfect model. And almost no breaks treatment, a lot of side effects, cognitive dulling, personality change, weight gain. He gained like 45 pounds, I think. He was only 10. And he left on this. I like that better. This is, again, is it realistic or pie in the sky? Well, we're going to find out. So, that's it.